Thank you. Good morning, Chairwoman, members of the committee. My name is Kevin Barone, and I'm here to ask for 3 bills to be introduced. There were bills you heard on the second to last day of session last year and didn't have time to work them. The first one, you want me to do them all?
Yes.
The first one is dealing with the naturopathic doctor's scope of practice, and it's RS 0639. The second one is dealing with the corporate practice of medicine, adding naturopathic doctors to that. That's RS 0614. And the final one is the Massage Therapist Licensure Act, and that's RS 0613.
Do we have any objections to this bill, these being introduced? Seeing none, those will be introduced. Thank you.
Thank you very much.
Oh, yes.
Thank you, Chairwoman. Mitch DePriest with 1861 Consulting, requesting introduction on behalf of the Kansas Association of Nurse Anesthetists, 23RS0540.
Any objections to this bill being introduced? Seeing none. Thank you. Today we have 2 presentations for the Kansas Health Institute. The first one is regarding suicide among adolescents and youth in Kansas. And before we start with that, Senator Petty has a point of personal privilege.
Thank you, Madam Chair. I'd like to introduce my intern. Go ahead and set up Madison. This is Madison Smith. Sorry, I couldn't see you around this. And Madison is a dual degree student at KU in health administration and law. So she's joined with us today. Glad to have you here, Madison.
Welcome, Madison. And let's begin with Wyatt Beckman, Senior Analyst at KHI. Welcome, Mr. Beckman, to committee.
Thank you, Chairwoman, members of the committee. Thanks for having us present our work on youth suicide rates in Kansas. The brief that we'll be talking about today, you may have in your packet. It's also linked in the slides. It looks like this. My name is Wyatt Beckman. I'm a senior analyst at the Kansas Health Institute. I've been with the Health Institute for 3.5 years. I'm originally from Ness City, Kansas, in Ness County, but now live in Wyandotte County, and am thankful and grateful to be here with you all and share this work. The Kansas Health Institute is a nonprofit, nonpartisan educational organization. We're located just across the street. We were established in 1995 by the Kansas Health Foundation. And we're committed to convening meaningful conversations such as the one today and supporting these conversations. On slide 4, you'll see some background of our recent work on suicide rates and suicide prevention. You can see that in the last couple of years, we've done done some work on rural suicide rates. All of the links are provided in the slides. Today, we're going to focus on our most recent brief, suicide among adolescents and youth in Kansas. On slide 5, you'll see some background on our methods. We wanted to look at the trends in suicide rates and the means of suicide. We used data from KDHE's Vital Statistics, KIC, and CDC Wonder. We used 20 years of data from 2001 to 2020, and there's my slides. Thank you. We used 20 years of data from 2001 to 2020, and we aggregated the data to 5 years. This allowed us to have more confidence in the analysis. The numbers are small, so just using a single year of data, we wouldn't be able to confidently reach some conclusions. And I would like to recognize Lauren Gracie. She's an epidemiologist here at KDHE, and she helped us with some of this data. Next slide, please. So now on slide 6, you'll see a map, and this is on the front page of that fact sheet as well. The map you're looking at focuses on ages 15 to 24. And all of the findings that are shown in the figures focus on that age group, 15 to 24. At 21.5 suicides per 100,000, Kansas had the 10th highest suicide rate in the nation for that age group. Kansas also had the 11th highest suicide rate for early adolescents, which is age 10 to 14. That is not shown on the map, but they had the 11th highest over that same time period. During 2016 to 2020, that 5-year time period, suicide was the second leading cause of death for both early adolescents and for youth. We chose to use a rate in part to help us better compare ourselves to other states and to show change over time. We know that population numbers change, and without a rate, we wouldn't have as much ability to see that change. So now we're going to look at the trend if you move to slide 7. So here's the trend in suicide rates, and you can see immediately a couple things. One is Kansas has been consistently higher than the U.S. overall over the last 20 years. Kansas is the darker line on the top. The bottom line is the U.S. total. You can also see that for both the U.S. and for Kansas overall, suicide rates have steadily increased. For Kansas, suicide rates increased by 63.8% from the first 5-year time period to the final time period. And this outpaced the 41.4% increase for the U.S. overall. In 2001 to 2005, the far left side, there were 271 suicides among 15 to 24-year-olds in Kansas. And by 2016 to 2020, there were 442. Now we'll turn to our final slide. And this slide focuses in on that final time period, so the 2016 to 2020. And we wanted to look at the means of suicide among males and females for that same age group. For our data source, there's 2 primary means. There's suicide by discharge of firearm, and then other unspecified means. And those are the 2 groups. Discharge of firearms is in the dark blue, and other unspecified means in the light blue. The first thing to point to is the very bottom in the gray box. You can see that overall suicide rates for males age 15 to 24 is higher than for females, 32.7 compared to 9.1. For male use, you'll also see that suicide by discharge of firearms was 1.5 times the rate of other unspecified means. In contrast, suicide by discharge of firearms among females was 1/3 the rate of other unspecified means. So said another way, 6 in 10 male youths who died by suicide died by discharge of firearm. For females, firearms accounted for 1/4 of female youth suicides in the same time period. We know from other data that wasn't part of our study, but from some work that KDHE and Lauren Gracie specifically have been doing, that suicide rates from our study we've shown are increasing. From her work, we can also see that suicide ideation, suicide attempts, and self-harm are also increasing. And in many cases, rates of suicide ideation and attempts can be higher for females than for males overall. That's the final slide. Thank you for your time, and I'll stand for any questions.
Thank you, Mr. Beckman. And since these are 2 completely different studies, we'll go ahead and ask questions now. Committee, do we have any questions for Mr. Beckman? Senator Holscher.
Thank you, Madam Chair. Yes, thank you so much for your presentation. I'm wondering if you can tell me if there are some notable differences in particular laws or trends or just things put in place in states like New York, the northeastern corner there looks like it has quite a bit of a lower rate, as well as California. Any attributable differences?
Thank you for the question. Our study did not seek to answer that specifically, but I can say a few things. If you look at the map on that first page, you'll notice that in general, suicide rates are higher among more rural states. And we know that nationally, rates of suicide are higher among rural populations and among certain occupations, such as farmers and ranchers. Suicide rates are also higher among veterans, which can be higher in rural areas. We also know that there are some notable suicide rate differences among race and ethnicity. In general, white individuals and Native Americans have higher rates of suicide. And those populations may be higher in some of these states that have higher rates. I unfortunately can't point to specific differences in laws, and our study didn't seek to answer that, but I'm happy to follow up with you. But it is worth noting that Kansas, unfortunately, is part of a broader trend among the U.S. overall of increasing suicide rates, and in many ways we share some similarities with other states that have some same situation as us.
Senator Petty.
Thank you, Madam Chairman. Your last comment about between females and males, so I'm trying to understand that. So actually, females, are you saying they commit or attempt suicide at a higher rate than males?
Our study did not specifically include data on attempts, but I'm happy to direct you to the data that I mentioned. But what we know is that what our data show is that the means of suicide for males and females is very different. And in general, firearms are very lethal means. And if an attempt is made with a firearm, there's a greater likelihood that attempt results in a death. So there can be differences in suicide attempts that look different than rates of suicide deaths, and that can be part of it. And I'm happy to follow up more, but our study specifically looked at suicide rates, suicide mortality, but the conversation around ideation and attempts is an important one to have.
And just as a follow-up, isn't this consistent? I mean, this data between males and females has been consistent over time that males are more likely to use a lethal weapon than females.
Yes, and suicide deaths by discharge of firearm make up about 50% of suicides overall across the country, and that's true for Kansas. But there are those known differences among males and females, and males die by suicide at a higher rate across all age groups than females.
Thank you.
Senator Stephan.
Thank you. Yes, interesting observation. You made the comment that it was clear that farmers and ranchers and military seem to have higher suicide rates. And I do think it's an interesting point that, as I grew up farming and ranching and still do, death is an everyday part of your life in farming and ranching as in the military. So, I think some of that is just due to a varying perspective of life and death. It's just an interesting concept that I had never thought of before, but should be considered in dealing with this sort of thing.
Thank you for the comment. And that occupation and rates of differences in rates of suicide among occupation wasn't a focus of this work, but there's some known data nationally that point to differing rates of suicide among different occupations and folks in different situations, and farmers and ranchers have higher rates of suicide.
Committee, other questions? Senator Baumgartner.
Thank you, Madam Chair. I was curious in looking again at that map, have you overlaid that with maps that show states with growing versus declining populations?
We have not, but I'll make a note of that, and I can follow up with you on that question.
I think that, Madam Chair, that would be interesting, because when I am looking at this, I am seeing some on that Venn diagram where those circles are almost on top of each other. I think that would be compelling. Thank you, Madam Chair.
Senator Erickson.
Thank you, Madam Chair. Did you look at anything, for example, there are a couple of outliers. Nebraska, for example, I would think would be somewhat comparable to Kansas, and Texas, parts of Texas as well, but they have considerably lower rates than we do. Do they have some type of program or initiative or outreach or something that we could model that would help lower our rates as well? Or what do you attribute the differences in like states or areas to in the rates?
Thank you for the question. I don't know of anything that I can point to right now that helps understand those differences. And if you look at some rankings for mental health between Nebraska and Kansas, for example, Nebraska says some similarly poor rankings. But that's a question I'd have to follow up with you on, of looking at specific differences in programs or laws or policies that could help us understand those differences.
Thank you. Thank you, Madam Chair.
Thank you. Any other questions from the committee? Yes, Senator Stefan.
Thank you. Could your epidemiologist give us any idea of what the margin of error between states is? Because I'm guessing they're completely separate reporting departments and entities and handled in different ways. So I wonder, how much slop, so to speak, is in those numbers on page 6?
Let's see which. With the map. So thank you for the question. So the map that we use or the data we use for the map is coming from the CDC, and they are receiving data from individual states, and at this time I can't speak to the procedures in other states and how our confidence or accuracy in those states, but this is the best or one of the best sources for these data that we have. And I have confidence in the CDC doing their diligence to provide good information.
Mr. Beckman, I have a couple of questions for you. I'm interested in the breakdown being ages 15 to 24. That's a pretty broad range. Do we have any more breakdown than that? Maybe teens compared to adults, of the young adults and the upper teens?
Thank you for the question. We used age groups that are included in the KIC data, the Kansas Information for Communities. So that's the age groups we worked with, and we can't further subdivide using that data source. But I'm happy to follow up with you and share this link. The data dashboard that I mentioned earlier does have some further breakdown and can separate out teens and young adults. And it is worth noting that this age group, when we think about prevention efforts or understanding intervention, this age group does span from in school or high school through college years and early adulthood. But unfortunately, the data source we chose to use, which is a good data source, but that's one of the limitations, is that's the age group that we have.
I see. So they had to have it listed as a compilation as opposed to per age.
So we, to have the groups to be able to compare, that's the age group that we have, is that 15 to 24.
And then my final question is interesting on the 4-year data, in that 2016 to 2020, of course we all saw the headlines of the mental health issues due to the COVID response and the suicides, quite frankly, very sad, tragic, in 2020. And so it would be interesting to know, to 2016 to 2020, we saw this jump to 21.3. I'd be curious to know what the jump was from 2018 or 19 to 2020 by the end of that year.
I think that's a really good question, and a question that has a lot of pieces to it and is beyond what we focused on. But I would note that if you look at that trends chart, we saw an uptick or starting of an increase even before the most recent 5-year period, starting around 2014 to 2018. So some of this trend, and certainly the broader trend over the last 20 years, preceded the COVID-19 pandemic, and we've certainly heard from folks in a variety of sectors ways that the pandemic challenged and made certain things more difficult. But I would say that, one, we don't have a great answer, but that trend was unfortunately there before COVID-19.
And it looks as though that was nationwide. All right, thank you so much for coming to committee today.
Thank you.
And committee next, we have Linda Shepard. Welcome, Linda. We've been friends for a long time. We knew each other way back. So I'll say, Ms. Shepard, thank you for being at committee, and she will be talking to us about the marketplace enrollment and the federal subsidies increase.
Oh, I wasn't even turned on. Sorry. Thank you. All right. As you can see, the brief that we shared with you is that the marketplace enrollment surged in 2022, certainly attributable to the additional federal subsidies that were available to folks who were interested in enrolling in this ACA coverage. The 2022 open enrollment was the first enrollment since the American Rescue Plan Act of 2021 increased the value of those advanced premium tax credits. And I just realized I skipped over my first page. So for plan year 2022, the open enrollment period ran from November 1st of 2021 through January 15 of 2022. And during that period, there were a little over 107,000 Kansans who selected or were automatically re-enrolled in a health insurance plan through the federally facilitated marketplace. And so that was an increase of over 19,000 compared to our 2021 enrollment. And again, as I started to say, the 2022 plan year was the first year that we had seen the increased advanced premium tax credits that were available to enrollees as a result of provisions of the American Rescue Plan Act of 2021. I did want to note on here, one of the questions that we often get when we're looking at this enrollment data is, okay, that looks like how many people enrolled or signed up for a plan, but how many people actually started paying for their coverage. And so in March of 2022, we had information indicating that about 102,000 Kansans had already started paying their premiums. So that was there. On page 7, again, I have just provided a really quick little graph there to provide you with some more information about the breakdown of new consumers, those that re-enrolled, and switching plans, and some additional things there that I was just going to put in there, but wanted to breeze over here so to stay within your time. So for plan selection for 2022, we had 7 insurers offering plans on the marketplace. So we had 123 total bronze, expanded bronze, silver, or gold plans for 2022. And then we also had a couple of insurers offering catastrophic plans. And you'll see a little bit of more detail about this later, but all counties in Kansas had at least 2 insurers offering coverage during 2022. If you look to slide number 9, 15% of our Kansas enrollees, so about 16,000 folks, selected a gold plan. So on the marketplace, some of you may be aware, we have, as I mentioned, we have the bronze, silver, gold, platinum. Kansas has not had platinum plans in the state available on the marketplace for a number of years, but we do have the bronze, silver, and gold. So we had 15% of our enrollees selecting a gold plan. And this is a fairly rich plan, covers about 80% of the health care expenses for a typical population during a year. Almost half of our enrollees, 52,000, almost 53,000, selected a silver plan, which covers about 70% of healthcare expenses. And then about 1/3, or about 38,000, selected a bronze plan, which covers about 60% of healthcare expenses. And again, on slide 10, again, just giving you some additional breakdown of those plans across the board for you to take a look at later if you'd like. So the financial assistance, ARPA, so the American Rescue Plan, increased the value of APTC and also extended that APTC to all eligible households with incomes above 100% of the federal poverty level. And I noted there that that's $26,500 for a family of 4 in 2021, which would have been the year that they would have used for calculating APTC for the 2022 plan year. And then, as you can see, nearly all, so 97,000 of the folks that did enroll during 2022 received financial assistance, either through that advanced premium tax credit, APTC, or cost-sharing reductions, and I'll talk a little bit more about that. So households with family income between 100 and 150% FPL were able to receive enough of that assistance to fully cover the premium for a benchmark silver plan. And about 1 in 5 Kansas enrollees were able to pay premiums of $10 or less a month with these enhanced tax credits. Also, as I mentioned, the cost savings reduction subsidies, Kansas enrollees with income between 100 and 250% of FPL, and again, I've noted there, that's $26,500 to $66,250 for a family of 4. We're also eligible for these cost-sharing reduction subsidies, which reduce their out-of-pocket costs. So when they buy a plan, you'll actually see a much lower annual deductible, and so once they cover that amount, then everything that they use after that is paid at 100% by the plan. And more than 4 in 10, or about 49,000, almost 50,000 of our enrollees received those cost savings reduction subsidies during 2022. One thing that I wanted to note that was interesting was that lawfully present immigrants with annual incomes below 100% also can qualify for APTC and cost-sharing reduction subsidies if they're not eligible for Medicaid or other or don't meet other eligibility requirements. And this is interesting because if you're a U.S. citizen and you make less than 100%, you don't qualify. So this is a special provision that was put in the ACA for these lawfully present immigrants. Also, U.S. citizens so as I mentioned, then U.S. citizens with family income under 100% and undocumented immigrants are not eligible for those that financial assistance on the market. So with that, I'm sure some of you have heard, we refer to that as the coverage gap. So if you make less than 100%, but you don't make a small enough amount to qualified Medicaid, then right there in the middle, there are no options for you to go either way, certainly on the marketplace at all. So for premiums for 2022, the average monthly premium paid by Kansas enrollees decreased from $116 per member per month in 2021 to $104 in 2022. The average monthly premium paid by enrollees without advanced premium tax credits, so these were the folks that went on and bought coverage even though they didn't qualify for tax credits, was $562 a month. So you can see very significant difference. Over the last 4 years, our Kansas enrollees have paid more on average than enrollees across all 36 states, including Kansas, that operate on the federally facilitated marketplace. And again, on slide 16, I've provided you with a little bit more detail about it. You can see the growth in the rate of the premiums just for this slide going back to 2019. So you can see in 2019, we were, for enrollees with APTC, we were a little bit lower than the U.S. average, but after that, we went up above what the national average was. Finally, on I'm going to refer you to the slide on 18 a little bit to look at this, but again, this is some detailed information showing you what the rates look like around the state. So you can see that enrollees living in Northeast Kansas, but that excludes Johnson, Wyandotte, Leavenworth, and Miami counties, paid the highest monthly premium on average, so $171 a month, which was 72.7% higher than our folks who live down in Southwest Kansas, who paid the lowest monthly premium on average at $99 a month. And again, as I said before, the average monthly premium paid by enrollees across the board decreased in 2022 to $104 a month. And again, if you want to take a look at the slide on page 18, and again, looking at the different parts of the state, and you can see what the average premium was for each of those parts of the state. And also one thing that we did include on here, if you had some follow-up questions, was at the bottom of that, at that chart, that figure that's on page 18, we have the FPL broken out, so you can see what those rates are. So, you know, it used to be with the marketplace that once you reach that 400% of federal poverty level, which you can see for 2021 was $106,000 for a family of 4, you were just not eligible for financial assistance at all. But what ARPA did was change that, so it does phase out very close to that level, but you were still eligible depending upon what the cost of the benchmark plan was for the state of Kansas, and nationally too, but in our case for the state. Also, I mentioned the data for the 2023 plan year that just came out literally yesterday, the final release. So that plan year ended on January 15th. And that data shows, again, another growth for us in Kansas. We were at a little over 124,000 people who enrolled this year, 124,000 Kansans that enrolled in the open enrollment that just ended. We will not have that detailed data like we have for 2022 until later this year. And Madam Chair, I'd be happy to stand for questions.
Committee, are there questions for Ms. Shepherd? Yes, Senator Thompson.
Thank you. Thank you, Linda. Sure. Number of questions. How many, we've got the number here of people, how many total plans are there in Kansas? I know we have 3 million residents or thereabouts. Mm-hmm. So this is about 3.6%. Are pretty much the rest of them on workplace plans, private pay plans? And do you know what the average premium for those might be?
I'll answer the first question, your last question first, which is I would not have the premium data, but so I think, let me make sure I'm understanding. The question you're asking is about what other types of coverage do folks have other than this marketplace
available
coverage?
To the marketplace.
Yeah,
right.
and Senator Thompson, I wish I could have had some other information, and we can certainly provide this to you later. So KHI, we produce a product every year that we call our annual insurance update infographic. And it does break down that, looking at the number of people in Kansas who do have coverage and the type of that coverage. So the most common amount of type of coverage in Kansas is folks who are getting their insurance through their employer.
Okay.
And so that's why we wouldn't have information about that, because that would be the company paying whatever is their plan. But most of the people in Kansas have coverage through their employer. Then you're right, then we have the people that are on the marketplace, obviously people who are on Medicaid and Medicare, and then there's obviously some military coverage as well. So it goes across the gamut, and again, I'm happy to share that.
I was just trying to figure out how many percentage we're actually talking about here. I mean, just calculating on total population, it looks like about 3.6%.
Yes, you're absolutely right. Yeah, this is a small percentage of, I mean, these are the folks that obviously in most cases are the people who are not getting coverage through their employer, but still want to buy it on their own in the individual market.
And if one follow, how many plans were available in Kansas prior to the Affordable Care Act being implemented? Do you know?
You know, I do not know that, and Madam Chair, you may actually know that better than I do. So I do not know the answer to that. Again, and by the way, the 123 plans that are on here, that's just what's available on the marketplace. Obviously, there are other plan offerings from the various insurance companies that operate in the state. Lots more than that 123, but that's just the number that's available on the marketplace.
Thank you. Thank you, Madam Chair.
And I would just say, I probably used the word friend too strongly, Ms. Shepherd, in that we knew each other when you were at the Department of Insurance, and as an insurance agent, of course, we talked often.
Right.
We did have 17 carriers prior to the ACA being passed, and each of them had multiple plans. As far as outside of the marketplace, I write all of those, very, very few options. You have a few short-term medical plans that are available, and then you have the Farm Bureau plans that are available, but most carriers do not offer plans unless they're through the ACA. Committee, other questions? Yes, Senator Pett.
Thanks, Linda. Thanks for the presentation. As I'm looking at the last table that you have on the state, but otherwise, so if we're talking about 250% of poverty, and you've got the family size there, that goes up to a family of 4 as $66,250. So what you're saying is that through the marketplace, because of the assistance that's available now, they are able at that level to still get some sort of a discount through the marketplace?
Yes, those folks are at 250% of the federal poverty level. They absolutely will qualify for advanced premium tax credits, so those dollars to help them pay their premiums will also qualify for those cost-sharing subsidies that I mentioned, which also reduce the amount of the deductibles and the co-payments and co-insurance that they pay for the plan.
But the reduction is not going to be at that $104 a month if you're at 250% of the poverty level as opposed to 100%.
I would say, and I'm not going to say yes exactly to that answer, but I will tell you that those folks that are in that 100 to 250%, that is really the sweet spot for the marketplace. And so if you're in that level, you're going to be able to max out pretty much your advanced premium tax credit and be able to qualify for a plan that you can pay, especially if you buy the silver plan. You'll be able to get pretty significant financial assistance to cover most of your premiums. So that really is the sweet spot there. And then obviously as you go past 250, it phases out and it's less, but that is the best place for them.
And that tax credit you said that the number of people that are using the marketplace has grown again this year in 23. Mm-hmm. So that same tax credit is still available to them this year?
For now, yes.
Okay, thank you.
Committee, other questions? I have a couple of questions for you. I've always found it interesting since the ACA was implemented that when we talk about average premiums. You and I both know there's not anything like an average premium. Premiums on the marketplace are based upon your age and your zip code and your income. Those are the only three things.
Right.
And so because of that, as you said, zip codes are very important, and you may have your zip code in Wichita or Western Kansas, and that will be a lot more expensive than somebody with the same income and the same age in a zip code in like Northeast Kansas. So we see a broad differentiation. The other thing is when we ask about what is the average cost of a loaf of bread, we don't say take into consideration the people that use food stamps. But here we do. We're saying you're getting health welfare, and we're going to take that into consideration when we look at the average cost of the premium and say, okay, so the average cost of premium is $167. Then you have people who go on there like, what? Mine's $500, and well, right, And I think this can be misleading to people. I get why you present it this way. That's how the federal government presents it as well. But I think it could be quite misleading when you have people, as I do every day, trying to help them find affordable coverage on the exchange. Have you heard anything from the federal government regarding what they call the family glitch? I know that they're looking at that this year.
Yes,
Could you explain the family glitch and what we're looking at?
Yes, Madam Chair, thank you for the question. Yes, so the family glitch is, the Biden administration had issued an interim rule about trying to address the family glitch, and actually that rule became final right at the end of 2022. And actually, those folks who now may benefit from that fix to the family glitch, and I'm sorry, I probably ought to explain what the family glitch is. So for those of you that I know Madam Chair knows this, but the family glitch is the situation that through the ACA, if you are an employee and your employer offers health insurance to you, if in determining whether or not that's affordable for you, there are rules in the ACA that talk about that coverage has to cost, your amount that you have to pay for that coverage can only be a certain amount. And if it's more than that, you can actually qualify to go to the marketplace instead. But the family glitch was that so if you're a family of 4 and your employer offers coverage, the cost for that family coverage may be considerably higher than the almost 9% of your household income that is available to your family. And so in the past, the rule has been, if your employer offers coverage, you have to go with that coverage. And they don't take into consideration how much of a percentage of your household income that coverage costs for you. So obviously there were a lot of people who said, I can't cover my family because the amount that they would be taking from my paycheck would be more than I could afford. So that was, but those people were also then disqualified from going to the marketplace. So you couldn't have the employees stay on their employer plan and then have the other however many family members go to the marketplace. They wouldn't be able to qualify for tax credits on the marketplace. So for this year, for 2023, that rule has been changed, and they actually extended the open enrollment period for those folks for another month to give them a chance to go in and take advantage of that if they choose to. So they fixed that.
So you received information that the family glitch rule was changed? Because I've not received that.
Yes. My understanding is that it has, and that they've extended and I'm happy to check with that for you.
Yes, would you please?
I will.
I would appreciate that.
Sure.
So basically, committee, if you are, and thank you, Ms. Shepherd, if you are on an employer plan, usually the employer wants to make most of the amount of money that they contribute to the employee.
Right.
That's who they want to make sure is covered. If you want to add your family members, many of them pay nothing towards the family members, and it can be quite expensive through employer-sponsored health insurance. So the way that they determined when they wrote the ACA is that if the employee's portion of the policy is more than 9.63, I don't know why that percentage, 9.63% of their income, if it's not more than that, it's considered affordable. Only for the employee, of course, but they still use that for the entire family. And of course, for many people not affordable for their family, they could still, yes, go to the marketplace, but they'll find those rates are very expensive because they don't get the tax credits. Many of us wonder if that was actually a tax family glitch, or it was actually written into the bill on purpose because it helped keep the fiscal note lower when the ACA was originally passed. So we don't know what that fiscal note will be, and that's what I'm understanding is the holdup on the federal level, allowing people to go to. Therefore, there are employers that say, we're not going to offer dependent coverage. By not offering dependent coverage, it actually allows people to go to the exchange and get a subsidy because it's not offered to them. So very interesting dynamic on employer-sponsored health insurance. And the last question that I have is, a lot of people don't realize we saw in your graphic the $12,800 for a single person is considered poverty level. And of course, if you work at McDonald's, you can make around $11 an hour. I believe the minimum wage in Kansas is $7.50 or something of that nature. Working at McDonald's for 25 hours a week, you can make that $12,000 $800 for a single person, and then they can get all of their premium paid for because they're at that, as you said, the sweet spot at the 100% level. I write for people every day, your employers, your plan on the exchange, lots of options, 0 premium, doctor's visit 0, specialist 0 to $5, total out of pocket between $120 and $250, generic drugs at no cost. For people who at least will work minimum wage for at least that number of hours to where they can reach that poverty level.
Yes.
Any other questions, committee? Yes, Senator Petty.
I just might say, as I heard you mention, anybody that's at 250% of poverty is not getting food stamps. So they're not getting that assistance at all. It may have changed slightly, but I know many teachers that for a family plan would be paying $1,600 a month. So the family glitch actually can help many to be able to afford to provide insurance for their families, which we know if we have families insured, we have healthier families in Kansas.
And do you have a response to that, or that was just a comment?
No, ma'am. Senator Petty, that's, again, as I said, when I was talking about the sweet spot, it was really just related to the coverage that they can get on the marketplace. And I am not familiar with those other benefits, but I understand what you're saying. And Madam Chair, again, you had made note of the fact that again, this is the data that we get from CMS, and so
Yes.
this is the information that we share about the Kansans who go on the marketplace and are getting that coverage. But that is also why we make note of the fact that that average premium was $562 for all of those folks who were not able to get the advanced premium tax credits to help them with
And I do
premiums.
appreciate that, because that is very helpful for folks who have sticker shock.
Right.
When they go on. And I agree with Senator Petty that the family glitch is a real issue. However, it'll be very expensive for them to implement that on the federal level because so many more people would be eligible for the subsidies than they are right now. So I would be very interested to hearing back from you if you've heard from the federal government that this has been implemented yet.
Yes, and I'm happy to do that.
Any other questions? Thank you.
All right. Thank you, Madam Chair.
Committee, we are adjourned.